A very good evening, everyone. I hope you are all in a very good mood now. Finally, exam is over. We are done with it, and you deserve a pat. I know all these competitive exams are a difficult nut to crack, but the happy time is here now. We are done with it. Those sleepless nights, those tons of revisions, and all that effort has gone into it is over. You've done it good, you've done it not up to your expectations, is not the time uh, right now to interpret what went wrong, to analyze how things were. Right now, just take a break. I don't say fal ki ichha mat karo. We all are working towards getting a good result and a result that we all deserve. But I would just say that right now, what you need is a relaxation. So just don't think. Whatever was to be done, whatever was in our hands has been done. So now, till we get the results, till it is with us, just stay calm, relax, keep your books on a side, and on a lighter note, let's just discuss how it was. What was the exam? So, through the recall, we do not mean to, kind of demotivate, or it's just an analysis of where you are going so that, you can just put in ki, haan, this is right. It's just knowledge sake. So it's revision and it's for others to revise what next. Okay. So with that, we'll start. I'll discuss the plan for this recall session is I'll discuss the questions, their answers, what went wrong, and all these questions are recall based. So they might not be just what you're looking for or what exactly was there in the exam, but it would be quite near to what was there. So the basic purpose is coming to the correct answer and the correct question. So if you have any suggestions, you're most welcome to tell me, right? So if all is good, please give me a thumbs up and we can get started. Good day, greetings, Rishi Raj. Warmly reciprocating the same to you. So, can I just have a thumbs up if all is working well so that we can continue? And after the discussion of the questions, we'll analyze how it was, right? Thank you, Renu. Thank you so much. All right. So, first, we'll start with this question. Patient presents with a visual field deficit, which is characterized by loss of left-sided vision in the left eye and left-sided vision in the right eye with macular sparing. Now, kindly note here what has been told to me in the recall is left-sided vision in the left eye. So, this is my left eye. So, left-sided vision in the left eye and left-sided vision in the right eye. So, that basically means what we have been doing again and again. It just means it is a left-sided vision loss. So left field of vision loss. So basically what we are dealing with is the field loss of left side with macular sparing. So now what is this known as? So basically now you get that point. Left eye, left side. Right eye, left side. So that means it's a left-sided visual field defect. When we talk of a left-sided visual field defect with macular sparing, the question says, what is this known as? So again, I'm telling you, even if you did not know anything about this question, basic question. Why basic question? It is time and again visual field, visual pathway, visual field effects we've been revising n number of times, and we have already done it so many times. Posterior cerebral artery involvement, there is macular sparing, right? And we all know I said, even if you did not remember or out of panic, you could not come to an answer, there is only one option which talks about macular sparing. Lag in the video. Now, is it better? Now, is it better? Is it better now? Okay, right? So, even if you did not know, there's only one option which talks about macular sparing. So, obviously, see, okay. So Rajashri says it was loss of vision in the right side of the left eye. So left side, right. Okay, left eye, right side, and left side of right eye, and left side of right eye. Okay, if I take that also, you say this is left eye and this is right eye. Let's see that. What do you mean to say? This is left eye, this is right eye. So you mean to say there was loss of vision in the right side of left eye, right? And left side of right eye. This is what you mean to say. So now what is happening? If this was the case, so this is a binasal field defect. But if you talk of a binasal field defect, that means where is the defect? In the temporal fibers. In the temporal fibers. But there is no location where you will have temporal fiber involvement with macular sparing. So, So by that I mean to say this cannot be the answer. If it was there, then it would either not talk of macular sparing, right? So this kind of a defect is a heteronymous hemianopia. Okay. So, but when we talk of this, that means when the optic chiasm, when the nasal fibers cross and the temporal fibers go uncrossed, so there has to be a defect in the somewhere here, which is bilateral, which is involving just the temporal fibers, right? And in that, if you talk of a macular sparing, that means the entire optic chiasm where the macular fibers were involved are spared. So that is something which is very, very, very rare. And uh, I kept reading question 5 times. Okay, so even if that you mean to say, if that was the option, that is possible only in very rare scenario. In that rare scenario, you have a bilateral lesion which is involving the temporal fibers of the optic chiasm. And since the macular fibers go here, remember we read that the macular fibers, they cross in the optic chiasm. The inferior fibers come anteriorly and posteriorly. We had read about the distribution. So if that comes, then there should have been heteronymous hemianopia with macular sparing. Then that should be the option. Was that an option, Rajshri? Was any time that an option? So what I mean to say is either there was no macular sparing here then. In that case, if there was no macular sparing mentioned in the question, then the answer would be heteronymous hemianopia to what Rajshri is saying, right? So then the answer would be heteronymous hemianopia, but the question should not have mentioned macular sparing. Okay, so if I go by your words, Rajshri, what you are saying, I agree. If that was the option, then I'm sure they would not have mentioned about macular sparing in the question. And in that scenario, the answer would be heteronymous hemianopia. Okay, but If the question was the way it is presented here, then the answer would be homonymous hemianopia with macular sparing. Are these right side of the right eye and right side of the left eye with macular sparing? That was the question. I'm quite certain. Okay. See now again. So Chrissy says right side of the right eye, right side of the right eye, and right side of the left eye. So even if that was there, again, Chrissy, that becomes a right-sided visual field defect. Even in that case, the answer would be homonymous hemianopia. Just pay attention. What do we mean by homonymous hemianopia? That means now what you're saying is this. If we say what Chrissy is saying, I might spell it wrong. I'm sorry. I will just correct it. Okay. So if what Chrissy is saying, you say this is left, this is right. You say it was right side of the right eye, and it was right side of the left eye with macular sparing. Exactly, this is what you're saying. So even if you take this as an example, again, this would be homonymous. So basically, you need to understand homonymous means same side. That is both eyes right side. Both eyes either right side or left side. So basically, same side. Homonymous, hemi means half, anopia means you're not able to see. So it would be homonymous hemianopia with macular sparing. With macular sparing, right? So either if you take my question or if you take the question which has been told by Chrissy, in both the scenarios, the answer would be homonymous hemianopia with macular sparing. It could be a right-sided visual field defect or it could be a left-sided visual field defect. Here, the involvement is of posterior cerebral artery. We all know that. But if I go to what Rajsri is saying, heteronymous hemianopia with macular sparing, I would not really go with it because it is not actually something which is to be asked at this level, right? It is so bilateral lesions which are just involving the temporal fibers and macular sparing is something which is very, very, very rare. Right? So options in the exam were homonymous hemianopia, heteronymous hemianopia, then these two repeated with added macular sparing. All right. So now again I have, so the two options what you need to say is there was homonymous hemianopia. All right. So we'll need to correct the options. So you say it was homonymous hemianopia, heteronymous hemianopia, and then with macular sparing. Is that right? This is what you all mean, right? So now, okay, so there has been a lot of confusion on this question. So now let me just clear it out. So what I have told you, the same-sided visual loss with macular sparing is what we classically study. Either it was left-sided in both the eyes or it was right-sided in both the eyes. With macular sparing is what I have been telling you is this homonymous hemianopia with macular sparing, right? It can be a left-sided visual field defect in both the eyes or a right-sided visual field defect with macular sparing. There is involvement of a posterior cerebral artery. So one option is that, if that was the case. But to what Sugha Janani and Rajasri is saying, that it was a heteronymous hemianopia which was mentioned, right? And the question did say, or the question did talk about macular sparing. And the question did talk about macular sparing with heteronymous hemianopia, then I would say if it was opposite sides in both the eyes, that means the left eye had a right-sided visual field defect and the right eye had a left-sided visual field defect. So that is this case what I'm talking, what is being talked about by Rajasari, and who else is saying, and Suga is saying. So these two scenarios which is mentioned by these two people, if this was the scenario, then the answer would be heteronymous hemianopia with macular sparing, right? Because you said the question did mention macular sparing. So if the question did mention macular sparing, it has to be in the answer, right? So if so now you know both these scenarios. So I am not in a position to say what exactly was there, but since there is a lot of confusion over this, so I would like to clear if the macular sparing was specifically mentioned in the question with heteronymous hemianopia, then that has to be the answer. So basically, what I mean to say is there are, like in this question, there is something which is a hint which is there in the question, which was here is macular sparing. So the macular sparing would come in the answer. So these two, anyways, go out of our options. So now out of these two, you know, if it was just the same side, it was homonymous hemianopia, and if it was the opposite sides, it is heteronymous hemianopia. So basically, is that point clear now? So now you know how to come to that point. Is that okay? I know there has been a lot of confusion, but I'm telling you, visual field effects is something which is going to be there in every exam, right? So that is something which you should know by heart. If you know the concept 1 plus 1 is equal to 2, it is just like that. Is that point clear to everyone now? Just give me a thumbs up, then I'll go ahead. I know there's a lot of confusion, but that confusion is because of the recall. Because, you know, somebody had read it to be right side or the left side. So that is the difference. But now I have told you, if it was mentioned macular sparing, there has to be that answer in the option. So there were just two options, and depending upon the sides involved, it could be homonymous or heteronymous. Is that point clear now? Everyone, can I have a thumbs up if that is clear? So this was, again, I told you, visual field effects studied so many times in the lectures. So this was something which was expected. This was something which we have done so many times. So it was for me and for all, it had to be +1. So there was no question of not attempting it, right? Okay. Is everyone clear with this? Then I'll move ahead. Can I have a thumbs up, please? Okay, then we move on to the next one. What is the most common intraocular tumor found in adults? So now, if I talk to you about this question again in adults, any changes that you would want to make to this question? Anyone? Was it this question? Okay, so when it says what is the most common intraocular tumor in adults, we have done it. We just did it the same way. Most common primary intraocular malignancy in adults, and we had done it so many times. Malignant melanoma of the choroid and the ciliary body. Remember when we did all the most commons, all the lines in ophthalmology, all the most commons in ophthalmology. This was the question. So this was the direct question from what we had done. So again, for me, it was a basic question. It was a basic question, and it has to be +1. So again, most common intraocular tumor in adults is, tell me what was the answer. Retinoblastoma, choroidal melanoma, hemangioma, rhabdomyosarcoma. What was the answer? The answer here was, yes, the answer here was choroidal melanoma. But this was, according to me, an incomplete question. It should have mentioned primary. But since it did not mention primary, even then the answer would be choroidal melanoma, because metastasis was not in the options. Metastasis was not in the option. So the most common intraocular tumor found in adults is metastasis, and number 2 is choroidal melanoma or malignant melanoma of choroid. But if you talk of the most common primary intraocular tumor, that is the malignant melanoma of the choroid. So this was a very simple question, right? We know what is retinoblastoma. So retinoblastoma is the most common primary intraocular malignancy in children. So that also we had done in childhood. What is hemangioma? Hemangioma can be capillary hemangioma or cavernous hemangioma. So this is the most common benign intraorbital malignancies. And what is rhabdomyosarcoma? This is the most common intraorbital malignancy of children, right? So clear about it was very simple. When we talk of malignant melanoma, so most common is choroidal, and number 2 is the ciliary body. So this I told you we had done so many times. This was done in most common series that we normally do. We learn about the most commons in ophthalmology. So again, it was a direct question. We have done so many times. This should not have been wrong. So quickly revising, most common intraocular tumor in adults. Number 1 is metastasis and number 2 is choroidal melanoma. But if we talk of the word primary, so the most common primary intraocular malignancy in adults is malignant melanoma. Number 1 would be choroid and number 2 would be ciliary body. And the same most common primary intraocular tumor in children is retinoblastoma. Then if you take off benign intraorbital lesions in children, we have capillary, and in adults we have cavernous hemangiomas. And then rhabdomyosarcoma, most common intraorbital malignancy in children. So was that clear? So that was +1. That was basic. Is that okay? Can we go ahead? All right. So now 2 questions +1. +1 each into both basic. All right. Then we come to the next one. The next one says a patient who works in an iron industry presents with iron deposits in the eye along with visual field defects. Which of the following condition is most likely responsible for this ocular finding? So please note which element are we talking about right here. I told you all the basic things, just write on a side so that there is no confusion. We're talking about iron. So what was the answer? Siderosis bulbi. It was very simple. First question says retinitis pigmentosa. If it was retinitis pigmentosa, was the person working in iron industry was mentioned. There are deposits in the eye. Why would retinitis pigmentosa have iron deposits in the eye? So it was not the answer. Retinitis pigmentosa, remember the classical triad we did. Remember what was the classical triad? So the classical triad was arteriolar attenuation, waxy disc pallor, and bony spicule-like pigmentation. So it does not mention, even if nothing of this sort is mentioned, there should have mentioned a history of nyctalopia, which is classical. So nothing of that. So retinitis pigmentosa is out. Siderosis bulbi, simple. Siderosis bulbi is when we are talking about iron. So that is because of iron. The causative agent is iron deposits, which get deposited in the lens, goes in the iris, and then goes in the retina. And all these lead to visual field changes. Hence, what is corroborating with what the question was asking? Hence, the answer here was siderosis bulbi. Then the next option is chalcosis. Chalcosis talks about which metal? Which disease? Which metal? Tell me. So, chalcosis is because of copper. So the question does not talk of copper, so out. It is not the answer. What is KF ring? Kesa Fletcher ring. Where do you get to see it? Wilson's disease. Wilson's disease is because of which metal? Again, copper. So it becomes so simple. So again, it was something which is very direct. Again, something which was basic to moderate. This was basic to moderate. It was a basic question, but they had presented in a case scenario, which I have always told you is going to happen in future. Case scenarios, case presentations, but it is so classically telling you about iron. So that is very, very important. Is that clear? Absolutely. Right? So everything, again, basic to moderate, this should have been +1 from my side because it was again something which was very direct. Again, I told you, you get so many hints in question. Everywhere, the hint is iron. The hint is iron. Iron industry. Iron deposits in the eye. So which other disease except siderosis is talking about iron? No other disease, none of the options. So it was something which was again very direct. Again, I would take it as basic, but if you want to see, it is something which is like a case scenario, so basic to moderate. So it is again +1. Classical question. All right, moving on to the next one. Suturing in cataract surgery is commonly performed in which type? It was again very basic. When we were doing surgery, cataract surgery, we were learning about cataract surgeries. We learnt about the incisions. Even if you did not know, you could remember it from the incisions. So let's see. It is phacoemulsification. You know it is advanced. Even if you did not remember. So there are always smarter ways to attempt the question. Extracapsular, flax, and manual small incision cataract surgery. So even if you did not remember, the smart way of guessing was the older types would have sutures. The one that we are advancing would be sutureless. Wasn't that the simple way to attempt it? Though it was the simple, direct question, right? So when you talk of phacoemulsification, remember we talk of foldable IOLs. So foldable IOLs means small incision. So phacoemulsification goes out of the options. Not possible. Extracapsular cataract extractions. So when we talk of extracapsular cataract extractions, the incision size was to the tune of 10 to 12 millimeter. So that would require the suturing. So answer here is extracapsular cataract extraction. So either ECC or ICCE would require suturing. What is flax? Flax is femtosecond laser assisted cataract surgery. So now again, if it is using laser to do a cataract surgery, it would either be further more refined. So this cannot be the option. Then it says manual small incision cataract surgery. Here everybody knows that we make self-sealing sclerocorneal incision is given. If ICC or ECC was not in the option, I could consider SICS out of the rest of the three. But since ECC was in the option, so this is not going to be the answer. So it was again something so direct, right? Simple. Any confusion still here? So again, this is basic. So out of the 4 questions we have discussed, see, everything is still basic. It is so direct, it is so basic, right? So simple. So you know phacoemulsification, you know flax, you know manual small incision cataract surgery. All do not require sutures except extracapsular or an intracapsular cataract extraction. So again, basic. Again, that should have been a +1, right? Very basic. Next, Fletcher ring is the deposition of. What else could be more simpler than this? Where do This was just done in FMG must knows when we revised everything. See, FMG must know session 1. We did all this. We did all this. I did tell you about Fletcher ring, and we did learn about it is because of iron deposition. So what was the answer here? Was it iron, copper, zinc, or molybdenum? Which disease do you get a Fletcher ring? Which disease do you get a Fletcher ring? It is seen in cases of keratoconus. So here, now I need to ask you, was it Fletcher ring or was it a KF ring? Because again, this question had a lot of confusion. Some said it was KF ring and some said it was a Fletcher ring. So just let me know, was it a KF ring or was it a Fletcher ring? Because had this been a KF ring, the answer would be copper. So KF ring is seen in, so when we talk of KF ring, where do you get to see KF ring? So now see, KF ring, Fletcher ring has been coming again and again. Metals, iron, copper coming again and again. Okay, Renu says the option answer is A. I agree. But what I need to ask you is, was it KF ring or was it Fletcher ring? So when we talk of KF ring, where do you see it? We see in Wilson's disease. We all know. And it is because of copper deposition. But if it was Fletcher ring, the way it has been presented, but if it was Fletcher ring, so Fletcher ring is seen in keratoconus, and it is the iron deposition which is seen at the level of the basal epithelium at the base of the cone. So then the answer would be, so what is Fletcher ring? Fletcher ring is basically which is seen in keratoconus at the base of the cone at the level of basal epithelium. So I've still not got the answer, still not got that whether it was KF ring or was it Fletcher ring. So if anybody can just confirm that whether the question was on the Fletcher ring or on the KF ring. What are your takes on this? Was it KF ring or was it Fletcher ring? I think it was Fletcher ring only. All right. Okay. Right. So let's see. So again, this was not at all difficult. It was a direct question. Keratoconus, we have learned it so many times, the signs of keratoconus. So again, I would call it a basic question and should have been +1. So till now, see, foreign iron body deposits, we have already discussed here, right? The one which had iron deposits. So this was, Shubham, probably you're talking about this question of an iron industry and iron deposition in the eye. So if it was a Fletchering, again, what Renu says, it was a Fletchering, so it is again a direct question. So again, it was basic, it was +1. So out of 5 questions, 4 have been basic, 1 I take as basic to moderate, again all plus 1. So simple. All right. Patient with a history of eye trauma with vegetative matter. Classical word, classical history. The causative agent under microscope. Now the uh, now the twist and turn starts. The causative agent under microscope is seen as septate hyphae at an acute angle. What are they talking about? This was a googly to play with your mind. All right. So this was a very smartly made question. It was a direct basic question, but smartly made to confuse you if you had gone to the second one. The first line says patient with history of eye trauma with vegetative matter. When you all know, when we are talking about vegetative matter, when we are talking about animal tail, when we are talking about farmer, what are we talking about? When we are talking about trauma with plant, trauma with vegetative matter, trauma with animal tail, what are we talking about? We are talking about fungal keratitis. So, even if you just read the first major point of vegetative matter, you would mark the answer correct as fungal corneal ulcer. The second line was more specific to a fungi, which I thought they would ask, but they made the question very simple. So now, if we take the second line, the causative agent under microscope was septate hyphae at an acute angle. This would have been a difficult question if it would have said identify the fungi. So if this would have been the question, then it would have gone to the category of very difficult. But just coming from with vegetative matter and whatever XYZ it says, the answer is fungal corneal ulcer. Now, if I would want to tell you that when they talk about septate hyphae, they are talking about aspergillus. This needs to be noted. They are talking about aspergillus. They are talking about aspergillus. Is that thing clear to in your mind? Yes. Very good, Renu. They are talking about aspergillus. Okay, so this should be very clear in your mind. But the question was absolutely simple. It said vegetative matter, and all you had to do was you had to identify which type of corneal ulcer. So once it says vegetable matter, once it says animal tail, once it says farmer, it is a fungal corneal ulcer. So I would call it as again basic and should have been +1 discussed so many times. Okay, so now you know if the other question is which is septate hyphae with acute angle, the organism is aspergillus. Simple. All right. So then we move on to the next one. So which dye or what dye is used for anterior chamber of eye? All right. If you say this again, I can take it as basic to moderate. And let's see what it says. Trypan blue, brilliant blue, fluorescein, and lissamine green. I take you do not know any of these dyes, trypan blue and brilliant blue. We know it is not fluorescein. We have read it so many times. Orange, orbs, gynae, orange dye, blue, irradiated with blue color, gives you green color, used for to stain corneal ulcers, used to evaluate the dry eye. So fluorescein dye not for the anterior chamber, because when once it's talking of anterior chamber, please note it is talking of intraocular use. It is talking of intraocular use. So fluorescein dye, extraocular use, which has been used in the cases of dry eye evaluation or in corneal ulcers. So this was not the option. Then lissamine green, no. Where do we use lissamine green to study the conjunctival staining patterns? So that was not an option. Now we were stuck with two, trypan blue and brilliant blue. So I always say when you reach two, it has to be attempted. You're getting a lag? All right, I'll just check once again. Just a second. I think now it should work properly. Okay, so now when we're left with two, trypan blue and brilliant blue, well, the answer here is trypan blue. Brilliant blue is something which we use to stain the posterior segment. That is the internal limiting membrane stain. So brilliant blue is a vital stain for the posterior segment. So out of the two that you had, the answer is trypan blue, which is used to stain the anterior capsule. So this was again a question from lens and cataract. So this I can take, all right, it was a basic to moderate because we all read so extensively about lens, about the cataract surgeries, again from the same thing. So it was again basic to moderate. So out of the 7 questions, this is one which I can think was a little on the difficult side, but still you managed to get onto 2 options. Okay, yes, it helps us to see the anterior capsule and do the capsulotomy or capsulorhexis, right? So the answer here is trypan blue. You all know fluorescein dye not used, lissamine is for conjunctival staining, and brilliant blue is a vital stain for posterior segment, right? So this is used in macular hole surgeries or for ILM staining. All right. Okay. So then we move on to the next question. A child. So all of these have been so basic except 1 till 7 questions. A child presented with jaundice. Okay. So the first thing is child inability to drink milk. The examination, there is oil drop cataract. The moment you read oil drop cataract, it had to stop here. The answer is galactosemia. So this is what I tell you is again so direct a question. I mean, what else can be so direct? Everywhere. Here, see, this is what I want to point out. Oil drop cataract, directly it is saying. If you see here, iron, directly it is saying. Macular sparing, directly it is saying. So many questions, you have a direct hint to tell you what is the answer, right? Vegetative matter, so direct, right? So what else do you expect in an exam if it is helping you so much to come to an answer? So the moment you get to see oil drop cataract, you all know the answer is galactosemia. There was no doubt, there was no need to read any time further. It was so direct. It was so simple. So we had done it so many times. The oil droplet cataract, which is seen in autosomal recessive condition, which is galactosemia. Right. So what other things, where do you get to see oil droplet appearance that you have? So you have a Charles sign or oil droplet sign that is seen in cases of keratoconus. So which other diseases does this word appear to us? So when we talk of the word oil, what all do we know with oil? We know one is what is talked about was oil droplet cataract. When it asks about cataract, the answer is galactosemia. When it talks about an oil droplet reflex, this is seen in keratoconus, which is also called as Charles sign. Last but not the least, oil globule appearance is also seen in posterior lenticonus. All right. Again, basic. Okay, if you don't want to call it basic, it was okay. I would not call it basic because it was done so many times in the class that I just thought it was so simple. But okay, I would take it as moderate, and this should have been +1 because the question itself answered said oil drop cataract. Had this not been given in the question, then I would have taken it as a difficult clinical scenario for you to reach out. But now, since it did mention oil drop cataract, I take it as basic, but if you say moderate, right? So is that clear till here? Now I hope there is no lag. Classical galactosemia, exact option given. Okay. All right. So that is also right. Okay. Thank you for that. I would correct it. So you say it was classical galactosemia, which is because of G put deficiency. Okay. All right. Simple. Are we done with that? Okay. All right. So next it says, in which grade of hypertensive retinopathy cotton wool spots are seen according to Keith Wagner classification. So now it says, okay, this I would take it as a difficult clinical scenario. This was a severe, or what is a difficult scenario. It did ask you a simple direct question again. So all they might be in a difficult scenario, but they were direct. It simply said I am talking about Keith Wagner classification. Which grade am I talking about if I talk of cotton wool spots? Simple. Okay. So here what you should know is, you should know what is Keith Wagner Barker classification. So what is Keith Wagner Barker classification? Let's quickly see. So when we talk of grade 1, we talk of generalized arteriolar attenuation. Okay, so we talk about generalized arteriolar attenuation. Then we talk of grade 2. So when we talk of grade 2, we talk of arteriovenous nipping plus focal attenuation. When we talk of grade 3, we talk of retinopathy. By that I mean there could be cotton wool spots, there could be hemorrhages, there could be exudates. And grade 4, when we talk of papillary. Again, I would say it was something again very direct. Though it did ask you to know about Keith-Wagner classification, which you can say is a little higher than what we expect, but yes, it was direct, right? Any confusions over this? So grade 3 was the correct answer. So here the answer was grade 3 because it is again talking to you about cotton wool spots which you get here. Cotton wool spots which is seen in cases of retinopathy which is seen in grade 3. Is that simple? Is that again direct? No confusions on that? So that was cotton wool spots and Keith-Wagner classification. Then we come to what are the yoke muscles of lever depression. How many times do I need to emphasize on this? I have been telling you again and again. Again, when we did it in Mission 150, I told you this is something which I am expecting. I am expecting yoke muscle, yoke muscle, yoke muscle. So many times I did tell you. And it is there in the exam. So, what did the question talk about? So, it asked you yoke muscle for levodepression, right? Yoke muscle for levodepression. Now, quickly to see, when we talk of levodepression, please note levo means left and depression means down. So, to look down on the left side. To look down on the left side. It was again simple when we talk of depression. So what are the muscles which play a role in depression? Anybody? So the muscles which act for depression is inferior rectus and superior oblique. Is that clear? And I had already taught you the mnemonic rub. Rub means God. So rub, God in Punjabi, we call it as rub. So by rub, I mean to say recti predominantly act in abduction. That means abduction. So when you talk of inferior rectus and superior oblique, when we talk of inferior rectus and superior oblique, so predominantly in abduction is inferior rectus. Similarly, so when we are talking of levodepression, when we are talking of levodepression, that means I'm trying to look on the left and down. So my left eye is depressing in abduction. So which muscle would act? Inferior rectus. So it would be left inferior rectus. Why? Because of the mnemonic rub. By rub we mean recti act predominantly in abduction. Okay, is that clear? So when I'm looking left and down, so my left eye is depressing in abduction. So recti act. So left inferior recti would act. And my right eye is looking left and down, which is depressing in adduction. So which muscle would act? Superior oblique. So here it would be right superior oblique. So that was a beautiful clinical application of yoke muscle. And what would be the answer? It would be right superior oblique and left inferior rectus. It would be right superior oblique and left inferior rectus. And those who have attended the classes with me, I always told you, before you start, please write down. You don't know whether there would be a question on the muscle action, but I always told you, before you start, just write down or draw that diagram that we had learned about the action of the muscles, so that when the question comes to you, there is no panic, because this is one part which everybody says confuses you once you are trying to solve that question. So this is my take for all the experience over years. Before you start your exam, before you start seeing the questions, just before starting, either write down the action of all the extraocular muscles or draw that circular diagram which we have learned. Is that okay now? Is that clear now? Now there should be no confusion on that. So levodepression, it did ask you about yoke muscles. For levodepression, this I would take as a difficult question because here it was levodepression. So this would be a difficult one. Is that okay with everyone? Can we move on to the next? Okay. So the next question says, patient comes to us with visual blurring. On examination, the diagnosis is made according to the image. What is the visual blurring called in this condition? Now, I want to know from you all, what was this question? Because I'm still not convinced it is actually what it was asked, because none of the options are actually fitting into this. And if truly this was the question, it was not to be attempted. It is as simple as that. Because when we talk of, let's see what questions. So, what are we dealing with? Basically, we're dealing with something with papillitis, right? So, because what are we trying to see? We see there is disc edema, there is the disc margins. So, if you see clearly what is there, so there are disc margins which are indistinct. There is disc edema. Then there are these hemorrhages. So basically, the question is talking about papillitis, right? Just if you could confirm me whether this was the question. And if you see this was the question, it says amaurosis fugax. Well, amaurosis fugax is transient obscuration of vision, which is primarily because of hypoperfusion of the disc. Is it central retinal artery occlusion? No. You all know what does central retinal artery occlusion give you? It gives you a cherry red spot. Is it a central retinal vein occlusion? No. Why it is not a central retinal vein occlusion? It gives you a tomato splash appearance. But here the image is classically focusing on the disc. Is it hypertensive retinopathy? Had this question said hypertensive neuropathy, I still would have taken. But this is not hypertensive retinopathy. Is it amaurosis fugax? So basically, if you are doing an exclusion, the answer would come down to amaurosis fugax. But what is amaurosis fugax? It is a transient obscuration of vision. And this is primarily because of hypoperfusion, right? So if at all you had to answer, the exclusion by exclusion, we come to amaurosis fugax. But classically, amaurosis also does not fit into this picture. So if it had to be answered, the answer would be amaurosis. Otherwise, for me, this had to be left like that, not to be attempted. Is okay? Can anyone confirm if this was exactly the question, or it was a different question? Anybody who would want to give me your take onto this, right? So if you had to attempt, if had to attempt was the scenario, then I would go with amaurosis fugax. Otherwise, I would rather suggest not to attempt this question because I'm still not convinced what are they trying to ask, right? Okay, so then we can come to you again, something which is very, very
I think the voice is creating a little issue. All right. So absent light reflex with accommodation reflex present. What is the probable diagnosis? So many times
we have done this so many times. Again, I would say this was a direct question. This was a basic question. Light reflex absent, accommodation reflex present. We are talking about here. Now the question is, did it talk to you about laterality? Did it talk to you about laterality? Was AD tonic pupil in the option? Because now, if it talks to you about unilateral presentation with light, this is light near dissociation. If the question was talking about the unilateral presentation, then it was adstonic pupil. But if it talked about a bilateral presentation, it was Ergile-Robertson pupil. Did the question talk about any laterality, whether it was a unilateral or a bilateral disease? Again, I told you, again, this question was in our mission 150. Again, one question which was anticipated and had come from our anticipation. Mission 150 was the one that we conducted just before the exam of the anticipated 150 questions that you must know. Again, it was from the same. So we did what we learned about was adstonic pupil. So if this was the question with laterality mentioned, now you know what was the answer. If the question did talk about a unilateral presentation, it was adstonic pupil. And if the question talked about a bilateral presentation, then it was Ergile-Robertson pupil. This is light near dissociation, where there is no light reflex, but the reflex to near, or what you say accommodation reflex, is present. So if anybody can just let me know if it's unilateral or bilateral, we'll be sure about it. Otherwise, if it I have told you what would be the probable answer, right? Okay, then it says an intra, then because I could not get the options, but I just could recall what my students could recall was certain questions. So I have included those here without having options so that we can at least know the correct answer. Intraorbital tumor, which was increasing on Valsalva. Well, it is again a classical question, but on your level, I can take it as to be a little difficult. It can be severely difficult. So the answer was orbital varix. Simple. No, nothing else you need to know. Nothing else you need to know. An intraorbital tumor which increases on Valsalva is orbital varix. Is orbital varix. Then short-term corneal preservatives. Short-term corneal preservatives was asked. They said there was a question on short-term corneal preservatives, and we did learn about this in advanced ophthalmology in for FMG preparation. We did advanced ophthalmology, and this was what we learned. So short-term storage, we learned two things: moist chamber and MK media. Right? So short-term corneal preservatives, there was a question on this. I'm not sure what exactly the question is. If anybody can just remember and let me know here. So basically here they must be talking about moist chamber or the MK medium. So MK medium is the McCarry Kaufman medium. So moist chamber preserves for 1 to 2 days, whereas MK medium preserves it for around 4 days. Again, this was a question which we had covered. So nothing was something which we had never learned about or talked about. Again, this was such a direct question. I am still unsure what exactly was asked, but everybody remembers short-term corneal preservatives, short-term corneal storage. So that means it was so direct again in the question. So is that okay? So it must have been something related to moist chamber or the MK medium, right? Then we come to the last question, panda eyes. Not really the last, but the 15th question, or where do you get to see the panda eyes, or what you also see is the raccoon eyes. This is also called as raccoon eyes. Where do you get to see this? This is seen in the fracture of base of skull. Fracture base of skull. So that was one question. So panda eyes or raccoon eyes are seen in fracture of base of the skull. Then again, drug used for refraction in a child presenting with squint. So drug used for refraction in a child presenting with squint. So here the catch was, whenever we talk of squint, we have to give the strongest cycloplegic. And the strongest cycloplegic, see, it clearly said the child has squint. So the answer was perfect. The answer was atropine. The answer was atropine. So anytime we're talking about refraction of child with squint, anytime we're talking about the first time refraction, it has to be done with the baseline evaluation under atropine, because atropine is the strongest cycloplegic, which is used as 1% atropine ointment, right? So that was again simple and direct. So till now, I have not got a question where it was a, kind of something beating around the bush and they wanted you to come to a point. So they might be beating around the bush, but they take you to a point which is a direct relation to the answer. So this is what I beautifully say of FMG. They do not let you be wondering about somewhere. They take you to the point and directly ask you a question. All right. So a known case of HIV, well, this was something which was a little tricky. A known case of HIV with reduced CD4 count presents to the ophthalmologist with the below given fundus finding. What is the drug of choice? And the image that was given was of a sauce and cheese chorioretinitis, or what is called as the pizza pie appearance. The pizza pie appearance, or salt and cheese appearance. So when we talk about this, we talk about CMV retinitis. Again, something which we have already discussed, seen in patients. This is the most frequent opportunistic infection, patients with AIDS, when the count is less than 50 cells per millimeter cube, and is the most common ophthalmic manifestation of congenital CMV, and giving you sauce and cheese chorioretinitis. Sauce and cheese chorioretinitis, pizza pie appearance, frosted branch retinitis, patient of HIV. It says reduce CD4 count. What are we dealing with? We are dealing with CMV retinitis. And what is the drug of choice for CMV retinitis? Perfect. The answer is ganciclovir. The answer is ganciclovir, which is given intravitreally for CMV retinitis. Again, a beautiful correlation when the questions classically says HIV with reduced CD4 count. They do not leave you anywhere unattended. They have not let your minds wander off. So they have clearly said HIV reduce CD4 count, right? So with that, so these were some around 17 questions. Some I could come down to the options correctly. Others I could not get the options, but I could get the questions. So if there are any more additions, what do you feel? So with this, what we always talk of FMG is, what I always say in FMG is, it is basic ophthalmology 70 to 80%, which is again seen here. Rather than saying it basic, I would now call it basic and direct questions, which is 70 to 80%. 10 to 15%, yes, they are moderate to severely difficult level, and 5% is advanced ophthalmology, where you, this time also, you had pizza pie appearance and short-term corneal preservatives. So FMG maintains to what we always talk, it maintains to its standard, it maintains to what we've been discussing, it talks about the basic and direct questions. But now, the best time is, it is now. It is time to relax. Right? As I said, I do not say fal ki ichha mat karo. We are all working to get that sweet fal, to get that meetha fruit of our efforts. But as of now is the time to just relax. You can choose any of the options of these pictures that you want to relax with, any of the ways you want to relax, but just de-stress yourself. You cannot take any more stress, any more tensions onto yourself. We've done it. Whatever we could do, we've done to our best. So now just relax, sit down. We've learned, we've seen what we did right, what we did wrong. It's all right. It's over. If we get something good, we take it. If we don't, it's fine. It's not the end of the world. There is still so many more other things, and we can put in more effort and we'll do it together. Right? So, with that, I would just say stay positive, all will be good, but be prepared for the worst. So that is my take. That is how I take my life as. I say always be positive, but be prepared for the worst. So either ways, it's not the end of the life, or it's not the end of the road. So whatever comes your way, we'll take it in a positive manner. So, well, this is my favorite way of relaxing. You can pick yours and do it. Till then, we meet next. I would wish you have a beautiful sleep, listen to beautiful songs, do whatever way you want to do it. I'll sign off now. I wish you all the best for the results. Just relax. All right. So if there are no further queries, I'll sign out. Is that all right? Okay. So I'll sign out. Take care. Bye bye. Good night.